Okay, so the objectives for the talk today are to review the various etiologies proposed for C. diff infection. We'll talk a little bit about the clinical presentation and how to make the diagnosis, relevant physical examination, and then summarize treatment and management options, which have kind of changed in the last really 6 months or so, and then a little bit at the end about infection prevention and control. So in 2017, IDSA and SHEA did a giant overhaul of C. diff recommendations. And they described things like the appropriate testing, when people should be tested for C. diff, defining different stages of C. diff, whether it's mild, severe, or fulminant. And then they had a whole section on treatment. And they basically categorized treatment by whether it was mild C. diff, severe, or fulminant. And so that's changed a little bit with the guidelines revisions that was done in 2021. They basically focused on changing the clinical approach to the patient with C. diff and how to treat them. So now they just talk about non-fulminant C. diff and fulminant C. diff when we talk about treatment, and then different categories like, is it the first episode, second, or multiple recurrences, or is it fulminant C. diff? So that's a little bit different than the 2017 guidelines. They also reviewed a lot of new data on fidaxomicin and also on bezlotoxumab, Zimplava. So they included a lot more information in the recommendations. And also, if you read the guidelines, they present a lot of evidence to support why they are making these recommendations. So actually, I recommend you reading the 2021. It's not real long, but it'll give you a good idea of what is the current recommended treatment for C. diff and why that is, why they made those decisions. So as everybody knows, C. diff is an anaerobic gram-positive spore-forming organism that produces toxins. It's very hardy. It lives on surfaces. It's hard to eradicate. That's why we keep people in isolation, like for the duration of their hospitalization. It can be found everywhere: water, soil, on fomites, of course, in stool. The mode of transmission is fecal-oral. And the two types of toxins that are produced are toxin A and B, and they're the virulence factors for C. diff. Antibiotics remain the leading risk factor for C. diff, especially cephalosporins, penicillins, quinolones, clindamycin. Clindamycin always got a really bad rap about C. diff because it was kind of the first antibiotic that was associated with C. diff. But all these other antibiotics can cause C. diff, and really any antibiotic, even like metronidazole, can predispose people to C. diff. So anything that changes the bowel flora is going to be a risk factor for C. diff. And then there's other proposed factors like advanced age, immunosuppression, chemotherapy, steroids, PPIs. People with chronic kidney disease, chronic liver disease, they're also at higher risk. But really, anybody can get C. diff. I actually had a patient one time that was young. He got admitted with like an arthropathy, an acute arthropathy, and he had one dose of amoxicillin and developed a post-infectious arthropathy from C. diff. So he ended up getting C. diff from the one dose of amoxicillin and then developed this arthropathy. So even one dose of the antibiotic, and it can be an antibiotic people got like weeks prior. It doesn't have to be current use of antibiotics. So C. diff infects about 500,000 Americans every year, and 29,000 of them have fatal outcomes within a month, with 15,000 being directly attributed to C. diff. And we always think of C. diff as a community-acquired infection, but actually 41% of C. diff is now, we think of it as a hospital-acquired infection, but 41% is actually community-acquired. So people in the community with any of those risk factors or antibiotic use. The CDC has addressed recently the misuse of antibiotic and has identified that as a major risk factor for C. diff. More than 50% of all hospitalizations will get some antibiotic during their admission. So that's a lot of people. And the CDC states that about 30 to 50% of antibiotic use is either unnecessary or people are getting the wrong antibiotic, or it's being used incorrectly. Wrong antibiotic, wrong duration, things like that. So antimicrobial stewardship is extremely important in trying to control C. diff. So C. diff can colonize the large intestines of any person, even healthy people. They can be asymptomatic carriers. Not everybody is, but a significant number of healthy people can be carriers. Antibiotics are the microbial flora of the large intestines. Well, they alter. Everyone knows antibiotics alter the antibacterial flora of the large intestines and predisposes people to C. diff. And then diarrhea and colitis, they're caused by Clostridial glycosylation exotoxins, toxin A, which is an enterotoxin, and toxin B. And what those toxins actually do is they become intracellular in the cells of the colon, and they can inactivate certain protein pathways. They can damage the colon cells themselves, and they can also disrupt intracellular tight junctions, and that's how it causes colitis. So that's the actual mechanism of what the toxin does in the colon itself. It basically disrupts the whole mucosal lining of the intestine, and then people develop the common symptoms of abdominal pain and diarrhea. Toxin A also activates neutrophils, the toxin A and B also promote chemotaxis, so it brings more white cells to the area, so more inflammation. So clinical signs and symptoms, I mean, most people are familiar, but we'll just go over them. People can be asymptomatic. Those people do not require any treatment. You don't need to treat people that are asymptomatic. If they got tested for whatever reason and they were asymptomatic, they don't need to be treated. Symptoms can be anywhere from just like abdominal pain and watery diarrhea, which are really the most common symptoms that we see. But people can have low-grade fevers. They can have nausea and vomiting. They can develop more severe colitis with toxic megacolon and ileus. They can even have perforation and sepsis and hypotension. So the spectrum can be anywhere from asymptomatic to very fulminant, with people even needing their colon removed and developing septic shock and even death from C. diff. Especially elderly people and people that are more malnourished, they're at very high risk for a poor outcome from C. diff. So the 2017 guidelines, they outlined like an algorithm on how to test. Before we used to do just a C. diff PCR, just the PCR test. That's all we did. But now they recommend a two-step, which this has been since like 2017. So first the GDH is done, and the GDH detects an antigen of C. diff. But that antigen is present in both toxigenic strains of C. diff and non-toxigenic strains of C. diff. So you need a second step to actually see if there's toxin present. So if your GDH and your C. diff toxin is present, then you have a diagnosis of C. diff. And I have a little algorithm here that I found that kind of gives you, first of all, who to test. So you're going to test people that have diarrhea. And it's interesting when you go see a patient, you say, do you have diarrhea? They all say, oh, yes, because they've had one loose bowel movement, like one day. But so if you round with me, I'm always like drilling down on that. Like, okay, was your stool watery? How many did you have? Like, how many did you have today? How many did you have yesterday? Because they'll just say, yeah, I had diarrhea because they had one loose bowel movement. So they should have 3 or more loose bowel movements in 24 hours. That's the definition of C. diff, not just one soft or mushy or watery stool. And I know it sounds ridiculous, but you'd be surprised. I mean, how many people they get labeled with diarrhea and the C. diff test is ordered because they had like one loose stool because they came in with like a UTI or something like that, and they had a little bit of diarrhea with it. So it's important to talk to the patient and find out, do they really have diarrhea? And then, of course, no recent laxative use in the last 24, 48 hours. And if you order a C. diff at TGH, you have to go through that algorithm. So it actually asked you that question. Does the patient have 3 or more loose stools in 24 hours? Has the patient been on any laxatives? And you have to check those boxes. And if you check yes, to the laxative box, they won't even let you order the test. And actually, Epic somehow knows whether the patient has had a laxative. So if you check no, and you still try to put it through, it'll come up, the patient's had a laxative. I'll let you proceed past that. So that's all built into Epic. I don't know about other EHRs, but here, yeah, it's hard to get past that It's pretty strict. They let you order C. diff on. And really, the main reason is because we had a lot of people that everybody was ordering C. diff for any kind of reason, like someone had a high white count, so they would get a C. diff. So there was a lot of people diagnosed with C. diff who really did not have clinical C. diff. So a few years ago, they changed it to make that, put all those criteria in there and make it a little bit more difficult to order, make sure it was ordered appropriately. So if they have an antigen positive and toxin negative, then a lot of times people will go onto a PCR, a C. diff PCR, to try to sort that out. And of course, if both are negative, then it's unlikely that they have C. diff. So that's a nice little algorithm that kind of walks you through the steps of ordering. So I just put the stool chart up here because people get confused about, what's diarrhea. So obviously number 7, where it's liquid, it doesn't take the shape of anything, that's diarrhea. And sometimes you might, like we recently talked to one of the patients, you kind of showed her the chart and said, well, because she said, oh, I'm having diarrhea. And actually she was having like this, like blobs. So, you have to educate the patient a lot of times. Not to say, I'm having diarrhea, and then that kicks off the whole cascade of events. And actually, in research, we have a C. diff study with a capsule. We give the patient the stool chart. It's part of the study material that they get, so they can actually record, because they have to have a diary and record like what their stools were like. So they get a copy of this chart to actually look at it and then record the correct, the correct information. So like I said before, in 2017, they kind of had the treatment guidelines according to the severity. So they had non-severe, severe, and fulminant. Now it's just fulminant or not fulminant. But to give you an idea of the severity, what it was based on, it was basically based on white blood cell count and creatinine. So non-severe was white count less than 15,000, and then a creatinine less than 1.5. And then in severe was defined as a white count greater than 15,000, and then a creatinine greater than 1.5. And then fulminant would be anybody who had toxic megacolon, ileus, hypotension, shock, things like that. Now, the severe and non-severe can be difficult in some patient populations, right? Because some people have low white counts, like all these organ transplant patients, their white count runs, 3,000, 4,000, and then at, Moffitt, those people have no white count. So you can't really use that in these people. Or if you have people with chronic kidney disease, their baseline creatinine might be, greater than 1.5. So you can kind of look at the change relative to what their baseline is, although there's no specific guideline that's recommended. But, you can look at that clinically and kind of try to decide, well, maybe this is a little more severe than I'm suspecting. They don't meet the numbers, but for some reason they don't meet the numbers. But it's not quite, it's important clinically to follow them, but in terms of treatment, it's not really that important, because really the non-severe and severe are treated the same. It's just C. diff and fulminant C. diff in terms of treatment recommendations for the new guidelines. So the newer guidelines now, the next few slides are all non-fulminant C. diff. So anything, mild, moderate, kind of severe, but not fulminant, these are the treatment guidelines, and they categorize them by whether it's the first episode, the second, or multiple recurrences. And you can see as we go through these that fidaxomicin has taken a much bigger role in treatment of C. diff. So the preferred regimen now for initial CDI infection is fidaxomicin 200 milligrams BID for 10 days. And of course, that depends on the resources in your area and whether the patient can get fidaxomicin, which can be a challenge because it's an expensive drug and it's not always available in everybody's insurance. They do have patient assistance programs. So if people have like commercial insurance, not Medicare or Medicaid, they can be eligible for a patient assistance program where they just really, the company pays for most of the cost of the drug, and the patient may have a small copay, usually less than $50. So if you have commercial patients, usually you can get fidaxomicin. You have to fill out a form and send it to the company, but it's a very quick process, and most of the times patients can get fidaxomicin. It's a little bit more difficult with Medicare and Medicaid because patients are not eligible for that program if they're on Medicare or Medicaid. Alternative would be vancomycin for 10 days, 125 milligrams. And you'll see throughout this, the vancomycin dose is always 125. It's not 250. It's the only time it's 500 is in fulminant C. diff. But you won't ever see 250 in these guidelines. So it's always 125. So it's an acceptable, but it's considered now an alternative, not the first line treatment. Other alternatives for non-severe would be metronidazole. If you're somewhere where it's just impossible to get oral vancomycin or fidaxomicin, then you can use metronidazole, but it's really not, the standard of care anymore for C. diff. Okay, and then that dose is 500 milligrams, hypo up there for 10 to 14 days. So, and note, Vanco is 10 days. It used to be 14, but now the recommendation is 10 days. And all these antibiotics, they also alter gut flora. So even though you're giving Vanco for the C. diff, it kills other stuff. So, I think it's important. Duration of antibiotics is very important. Not to go past, unless there's a really good reason, to do it, because it does have other, other effects. So then the next category would be the first recurrence. So again, the preferred is fidaxomicin, which is, again, 200 milligrams twice a day for 10 days, or, which I didn't know this till I reviewed these new guidelines, you can do fidaxomicin at the normal dose for 5 days and then do what's called like a chaser. So it's every other day for 20 days. So that can be a consideration for the first recurrence of C. diff. So either another full course of fidaxomicin or this longer kind of tapered course. Or you can do vancomycin as a tapered dose. One of the examples is 125 4 times a day for 10 to 14 days, then twice a day for 7 days, and once a day for 7 days, and every other day for 2 to up to 8 weeks. And that would kind of depend on, the patient, how sick they are, and what underlying factors they might have, like immunosuppression, or if they're on chemotherapy or steroids or things like that. So that can be an alternative. And you can also kind of take into consideration, what did you use for the first round of treatment? Like if you used metronidazole, then you should use either fidaxomicin or vancomycin. If you used Vanco PO, you might want to consider doing fidaxomicin as your second. So think about what do they get for the first round of C. diff treatment. An alternative is, again, like I said, C. diff or Vanco in the usual dosing, but that's depending on if they had something else the first time. And then even in the first recurrence, now they do recommend considering Zimplava, bezlotoxumab, as a one-time infusion. So bezlotoxumab is a monoclonal antibody against C. diff toxin. It's an infusion, and it has to be given while the patient is still on their course of their current treatment. So you don't give it after they finish their C. diff treatment. You have to give it while they're on their treatment. We actually are able to give this in our infusion center. So we have the patient come in, like say if they're on, say they have a recurrence and they're on maybe a Vanco taper. Sometime during that taper, we have them come in and get their dose of Zimplava. And so, like I said, it's a one-time infusion. Takes about an hour to give it. I think I have a little more information on that coming up. Okay, then second recurrence or subsequent recurrences. These are some of the treatment options. Again, you can do that fidaxomicin 5 days followed by the 20-day every other day course. You can do the Vanco taper, again, depending on what they had the first 2 times, right? So you try to use something different if you can. There's also the vancomycin followed by rifaximin for 20 days. That's another option for the second or further recurrences. And then you can consider doing fecal microbiota transplantation if it's available. That's usually going to be an outpatient procedure. That's done usually with stool that you get from a company that is called Open Biome, and they collect the stool, they screen it for any kind of transmissible disease, and then they ship it to you, and you have to put a NG tube into the patient, and then you give them the fecal transplant And actually, at that point, they stop all their C. diff medications. They don't take any more. They don't. And you can do that either when they're on treatment and then stop treatment, or you can do it later. Like say, you can do it like a week later or 2 weeks later or whatever. So you don't have to do it while they're necessarily on treatment. It can be hard to get because a lot of insurances don't cover it. So patients a lot of times will have a big bill or they can't afford it. So that's a problem. We used to do it in the hospital, but we don't do it at Tampa General anymore. I don't know about VA or Moffitt if they're doing it there, but we're not doing. You guys are doing it.
We used to do it. I don't even know if it's COVID we've done any.
Open bio, I'm not sure if they're giving out that much to
Yeah, so they were not distributing any product for a long time because of COVID, but now you can get it again. We just started doing some fecal transplants in the office again.
Yeah, I contacted them recently. They resumed their output, but they're pairing up with, I think, the University of Minnesota, who's going to eventually be providing their sample, their product. So it's kind of in transition that you can either get it from University of Minnesota or you can get it from Open Biome. But at our facility, we haven't started it up yet. So, but I understand at Bay Pines, they're resuming some of that through the GI department. That's what we heard.
So our office, we've been able to restart that just very recently, though, with a few patients. There's a couple doctors in my office that do it, Dr. Noel and Carrington. So they just started back up. Apparently, you can also do Open Biome also has a capsule product that you can give patients, but it's 30 capsules that they have to take pretty much over like about an hour period.
And in the interest of disclosure, when I called them, because the job was going away, and they just had the standard product right now.
Noel was telling me, Dr. Noel was telling me about that because I wasn't actually aware. And she was, she pretty much always uses the NG tube, the liquid product. Now, there are some studies ongoing. We actually have a study at Comprehensive Research with another product that is 10 capsules. So, and it's been through the initial study. I think it was the initial phase 3, and they had good results. So now they've gone to an additional phase 3 study looking at that product versus just standard of care, or well, it's actually double-blinded placebo controlled. So it's randomized 2-to-1. So 2 people to every 1 get active product versus placebo. So we do have that study. So in the future, hopefully there'll be an oral product with a lot less capsules, but not right now, not unless you go into a study. So. There's the fecal transplant. The authors of the paper, they recommend it for people who've had at least 2 recurrences, so 3 episodes of C. diff. And then again, they have Zimplava. I'm going to say that because that other word's hard to say, as also a drug to consider for people that are, have had multiple recurrences. Now, if you gave it early on, you're not going to give it again because it's a one-time. So if you had it, if you got Zimplava during your first recurrence and you get C. diff again, you're not eligible to get it another time. It's a one-time thing. Any questions?
Do you know if the data for Zimplava is very robust?
I actually have a slide on that. Question? That's coming up. It is against toxin. It's in my slide. Is it B? Yeah, I forgot toxin. So then fulminant C. diff, the treatment is high dose oral vancomycin, 500 milligrams QID, and then IV flagell. So combination of PO and IV. Sometimes people do vancomycin enemas if they have a really bad ileus and the vanco is just not going to get to the bowel. Then vanco enemas are an option. And again, the fulminant would be people in septic shock. They have a big ileus. They have toxic megacolon. They're really, really, really sick.
Dr. Mayer.
Yes.
I know we talked about this before, but can you remind me, what is the definition of recurrence? Is it like another episode in the same 6 months, like recurrent C. diff?
Well, actually, it's any recurrence.
Like any time, any lifetime. Okay.
Right.
Okay.
Like if you had C. diff and then a year later you get it again, then that's your second episode of C.
So
diff.
it's like lifetime.
You can have like C. diff and then just fail your first line of treatment. You can have C. diff and then have a relapse. But if you have another episode after the first one at any time, that's your second episode.
Okay.
Okay, so the experts asked a couple questions in this new, when they reviewed these guidelines. And one of the questions is, what would, in patients with initial C. diff, should you give fidaxomicin rather than vancomycin? So they reviewed all this new data, some new clinical trials, a meta-analysis of all the old trials, and then they came up with these opinions. So these are the opinions of the experts that were on the panel for that new publication. So fidaxomicin, the evidence for the fidaxomicin is that it's orally delivered and has minimal absorption, so minimal systemic absorption. It's highly effective against C. diff, and there really hasn't been much in the way of resistance reported. Fidaxomicin doesn't have any other treatment indication, and it's narrower spectrum, so it doesn't affect the bacterial flora as much as like vancomycin or flagyl. In terms of initial clinical response between fidaxomicin and oral vancomycin, they're the same. So the initial response rates are similar. Where fidaxomicin is better is that there's fewer recurrences. So that was the reason that they basically recommended fidaxomicin now as the preferred agent. So there was no difference in mortality, and there was no difference in drug-related events, but less recurrences of C. diff with fidaxomicin. So it might be like really important to try to use that for people who are at high risk for recurrences. So maybe the healthy person who has one episode and it was antibiotic related, maybe fidaxomicin might not be as important. But if you have an immunosuppressed person or a person on, chemo or steroids or some kind of chronic disease, they're at higher risk. So, or people that might require additional antibiotics, other systemic antibiotics, fidaxomicin might really be a better choice for those people to lessen the risk of recurrences. And then that was the initial episode. So in terms of recurrent episode, again, they looked at studies to see whether fidaxomicin rather than vancomycin should be used in recurrent C. diff. And again, fidaxomicin showed a better sustained response at 30 days, so less relapses. Again, comparable initial cure rates and no change in all-cause mortality. But when they looked at like a subgroup of people that had one or two or more recurrences, then actually fidaxomicin performed better than vancomycin. So the more recurrences you had, fidaxomicin tend to cause a lot less recurrences than people that had just one or were on vancomycin. And then the data for the pulsed fidaxomicin comes from in vitro gut human model studies. And then there also have been some reports of, reports of people using that regimen and having good outcomes, but the author stated there needs to be more randomized clinical trials needed. But they had a lot of case reports about people getting the taper dose and doing well. So that's where that comes from. And then in terms of Zimplava, whether that should be used or not, so there it's against toxin B. It was actually approved in October of 2016, and the actual FDA indication is for prevention of recurrence in C. diff in high-risk populations. So in the FDA indication, it doesn't say it has to be the second or the first relapse or the second occurrence. But the FDA indication is for people at high risk of recurrence of C. diff. It doesn't stipulate whether it's the first episode or subsequent. But in the guidelines, as you saw, they basically recommended in the first relapse or second or other relapses. So that's a little bit different than what the actual FDA indication is. It's infused over 60 minutes. The antibodies last about up to 3 months in the body, but there's no data for giving another dose later. At this time, there's no data for redosing later after that period of time. So 2 randomized clinical trials demonstrated a reduction in C. diff recurrences at 12 weeks. and also reduce hospital admissions at 30 days, but no reduction in mortality. So in patients with recurrent C. diff, within the past 6 months, the panel suggested using Zimplava as a co-intervention, as you saw on those treatment guideline slides. And then again, especially in people that are at high risk for relapse. That's a lot of our population now, right? A lot of people are on biologics, and we have a lot of transplant patients and people on steroids. So it's a large number of patients. I've used it on like some solid organ transplant patients who had just their first episode of C. diff, because I felt like they were at a very high risk of recurrence, although that's not exactly what the new guideline says. And most people have tolerated it well, and one or two have relapsed, but the majority seem, this is just observational, I don't have any numbers, but most of them seem to have done well. You have to give it with caution in people with heart failure. And then cost can be an issue, accessibility. But again, if they have commercial insurance, there's a good chance they can go through that program that the pharmaceutical company has and get the drug. Oh, also, one other caveat is that most of the Zimplava data is with Vanco, so there's not a lot of data with fidaxomicin. So infection control, a lot of you guys might be doing infection control. When you finish your fellowship, you might have a infection control contract at a hospital or nursing home or other facilities. So C. diff isolation is a little bit better than a little bit different than your standard contact isolation. People need to, of course, do hand hygiene, wear gloves and gowns when they leave and enter the room. We've allowed visitors at Tampa General to not use PPE when they visit MRSA patients or VRE, but they're still supposed to wear the PPE when they visit a C. diff patient. So that's kind of important to know. If you order a C. diff test, you think someone has it, you should put them in preemptive isolation until you get the result back. Soap and water is the best, although I did see some data about using hand gel, but I don't know, I'm still a soap and water person, and getting those spores off your hands I think is a good idea. People should be in a private room with a dedicated toilet. If you have a facility where there's not enough beds and you have to cohort people, make sure you put people with the same resistant organism in the same room. So 2 C. diff people can be in the same room, but not a C. diff and an MRSA, or something like that. It has to be matched. Now, you'd be surprised what goes on some places. And then terminal cleaning with sporicides and using disposable equipment. Now, a lot of times family members will ask, well, what should I do at home? Because they're concerned, that about spreading it around or getting it at home. So I always tell them to wash all or clean all high contact surfaces with bleach, and the dilution is 1 to 10. So some kind of diluted bleach solution. And I tell them clean anything that people touch a lot, like faucets, door handles, surfaces, anything with a bleach-based solution. And then, of course, good hand washing. But a lot of people ask that question, well, what should I use? Should I be concerned? So you can give them that advice. So that's the infection prevention, and that was my last slide. So we can take a few questions if people have